Hi, Dave.
How are you?
Hi, good. How are you?
Good. Nice to see you.
Yes, you as well. Thanks for joining us.
Absolutely.
We might give it a few minutes to let people come in, if that's okay, and then I can introduce you
Yeah,
and give it over to you.
that sounds great.
And you should be able to share screen, so let me know if there's any difficulty doing that.
Okay.
I think we can go ahead and get started. People might come in, but I just want to make sure that you have enough time for your talk. So, hi, everybody. I'd like to introduce Dr. David Zoff, who is an associate professor of pediatric otolaryngology, as well as an affiliate professor of biomedical engineering here at University of Michigan. His clinical focus is in caring for children with congenital malformations of the head and neck. He's part of the scaffold tissue engineering group in the Department of Biomedical Engineering, where he and colleagues have led the field of medical 3D printing to aid in treatment of these patients. Among other innovations, his team has developed a patient-specific 3D printed airway splint, culminating in a landmark New England Journal of Medicine article detailing this innovation, as well as the potential of 3D printing in general for the production of personalized medical devices. So we're really excited to have you here for our grand rounds today, and thank you for joining us.
Well, thank you so much. And this is such a great group, and a lot of the work that we're doing is in part because of a number of individuals in the department and on the call today. So excited to have team members like you guys. Let me pull up. Is this showing okay for everybody?
It's in your view. There you go. Now it's in
Okay, great.
presentation.
So this is kind of updates on a clinical trial that we have ongoing. And just as way of disclosures, we have NIH funding and some IP that this has generated. I just want to take a few moments. I just got back from Australia, and this was amazing sleep surgery meeting. But the keynote speaker was Dr. Colin Sullivan, who is credited with inventing CPAP, and it was a huge honor to meet Dr. Sullivan, and we actually chatted at length throughout the week. It, I was a little bit expecting, because it was kind of the focus was a sleep surgery meeting. I was a little bit expecting him to give his keynote and then kind of scoot on out. But to my amazement, he stayed for the entire meeting, was incredibly engaged in the entire meeting. Even some of the surgical talks, and I was really impressed at his level of engagement. He did state that he was anticipating that this was going to be kind of his last, big kind of talk and conference. But a couple of things that really struck me, his title slide, which is one of these title slides where it's like a little bit of the mic drop before he even starts speaking, right? When you have the title of your talk be Sleep and Breathing, a 50-Year Odyssey, the title is a lot cooler than my title is. I'll say that. And it's an impressive title, right? Like it's one of those titles that I don't know. I'm just incredibly impressed with Dr. Sullivan, with his body of work. And then one of his final slides, is this is so impressive to me too. Just thinking about CPAP as, an experimental tool and method. This statement that, the therapy was invented before the problem was really defined and fully understood. And we're still learning so much about sleep apnea. And then really kind of this idea of a therapy that was a driver of, clinical sleep medicine is just pretty remarkable. One thing you'll note is that the introducer, Lyndon Chan, is wearing some attire that is pretty relaxed. So the meeting attire was pretty relaxed, and Dr. Chan really led the way with that. So another kind of fun thing was the meeting was at Wollongong. Well, they had a gong. I don't know if you can see that golden gong. And the way they, let people know that the talk was meeting time or needed to kind of hurry up, at a minute before your talk was done, you got one gong. And then if you met your time and you started to go over, Dr. Chan would continuously gong. So it was like the Oscar music, the Golden Globes music to an extreme. This is a picture of the first kind of CPAP machine, which I was really, I thought interesting, and seeing a lot of like the development of, CPAP, and then this was kind of the first time that Dr. Sullivan demonstrated that, the CPAP was able to turn off the apneas. And his wife was there at the meeting too, and it was really endearing, hearing her and kind of in discussing with her and talking with her too, hearing like her elation when he came home and described, that it worked, and he was kind of jumping up and down in the middle of the night. And interestingly, he describes this fact that his wife was having a recurring dream of him stopping sleeping and like gasping for air at night. And as they discussed it more and more, he actually was, and he was having apneas. And so he ended up getting diagnosed with sleep apnea himself. And then maybe kind of the biggest response from the audience is when he was talking about using the CPAP, and he said, "There's no way I'm going to use that bloody machine." So he had a hard time tolerating it too. But it's interesting kind of seeing you know, how the masks were iterated and developed on. You see a lot of, molding processes. And then, when we compare some of the things that we've done in our group, they're pretty similar as far as kind of development. We've got some tools now that, that weren't available in the 80s, like light scanners, laser scanners, and 3D printing. But the meeting in Australia, if you've not been, was really beautiful. I would encourage you to check it out if you've not been. It's worth the 20-hour flight, I would say. This is one of the first, this is the oldest hospital in Sydney. And it's interesting how like the city was really built up around this. And the cafeteria food here is better than ours at Mott Children's. So now we'll jump into our work. And what we're focusing on is obstructive sleep apnea, particularly in children who have really challenging hypotonic obstruction, children with cerebral palsy and trisomy 21. And then we'll describe some of our team's efforts in developing a novel treatment solution, which is a nasopharyngeal device. And so cerebral palsy, we know, is one of the most common motor disabilities in childhood. And not surprising, with some of the impact to tone in these children, we see an increased incidence in obstructive sleep apnea. What has been surprising to me is, for several years now, we've been working on this, and certainly initially, the amount of literature in this area of cerebral palsy and obstructive sleep apnea is maybe less than I would have expected. One thing that we've done is kind of look at University of Michigan's retrospective experience with cerebral palsy and diagnosis of obstructive sleep apnea. And so we've looked retrospectively 10 years, and a really great cohort of patients to look at. And of those, about 1,700 children with cerebral palsy, not as many as I would have expected had sleep orders for sleep evaluation. Of those patients who had a PSG, most of the patients had obstructive sleep apnea, and you can kind of see the breakdown between mild, moderate, and severe. I think, one component of this NIH are one thing that I would like to try to achieve is kind of increasing, kind of the recognition and diagnosis of obstructive sleep apnea, and ensuring that we're able to do that well. I think that it's a challenging population, in particular because a lot of the treatment options, which are the usual treatment options, are challenging for patients with cerebral palsy. So, whereas most children do quite well with adenotonsillectomy, it's more of a challenge, a big challenge in patients with cerebral palsy. And things like positive pressure, which can work really well, can be a big challenge in patients with cerebral palsy. So we know for some of these patients, it can increase the risk of aspiration. Many of these patients with severe cerebral palsy are at risk for aspiration pneumonia. And many of these patients can have difficulty removing the mask, so they may be an asphyxiation risk as well. We also know that, similar to what we found in our review at Michigan, not only do patients with cerebral palsy tend to have obstructive sleep apnea, it tends to be on the more severe end of the spectrum. the decision to kind of proceed with adenotonsillectomy is a trickier one for multiple reasons. One, we know that again, these patients tend to not do as well as otherwise healthy patients with adenotonsillectomy. And then the perioperative risk for these patients is one of the highest when we consider, other medical comorbidities. And so typically these patients are requiring ICU stays postoperatively, and their length of stay, whereas otherwise healthy children can frequently go home same day or next day. These patients, it's not uncommon that they're in the ICU for, 1, 2, 3 weeks postoperatively. 2 studies looked at how do children fare with adenotonsillectomy or uveopalatal and a striking number of these patients end up going on to get a tracheostomy. And so I was, kind of early in my career as faculty, I was kind of contemplating on this patient population, and it was challenging to have this discussion with families that really the 2 options for these, many of these patients was tracheostomy or palliative observation. There were certainly a number of patients who the families really were not on board with the idea of tracheostomy, kind of the idea and the changes that would result in, both for the patient and for the whole family unit. They're not interested in pursuing tracheostomy. And so I really wanted to see if there was something we could think of that was somewhere in between, right? Really between tracheostomy and just palliative observation. And so was fortunate to assemble a great group, Louise O'Brien, Jeff Plott, Ron Chervin, Fauzia Hassan, who helped think about a potential approach and how we might study that approach. And I kind of drew on my experience with children with Robin sequence. And there was one clinic in particular that I had where I had scoped, I think maybe 3 or 4 patients with cerebral palsy. And as I was doing this flexible laryngoscopy and seeing the tongue base collapse, it was very kind of reminiscent and reminded me of patients with Robin sequence who, those infants, micrognathia, glossoptosis, really retrolingual collapse, tongue-based collapse. And I've treated those patients quite successfully with a nasopharyngeal airway. And that experience I took from the Great Ormond Street group, who they had a paper about 10 years ago that describes an 11-year experience in treating Robin sequence infants with nasopharyngeal airways. And what they found was that with a few months of growth, those children could really kind of outgrow their glossoptosis and upper airway obstruction. And so we kind of started the design of the device really around that nasopharyngeal approach. And what the Great Ormond Street group utilizes is a modified endotracheal tube. And we kind of thought about, well, what are the benefits of that endotracheal tube? And then what are the challenges? Some of the things that are not ideal with the endotracheal tube is that, it very much looks like something out of MacGyver, where we're, using a clothespin and tape and taping the device to the infant's cheeks. And so I wanted to develop a way that the device could be comfortably inserted, not be dislodged, and also the other challenge with endotracheal tubes is they get obstructed and occluded with secretions and if they're kind of adjacent to the oral mucosa. And so we wanted to be able to optimize airflow with the device so that, even if the end of it is occluded, you'll still get, good airflow. So the device goes in the nose, bypasses the retropalatal and retrolingual upper airway obstruction. Originally is not intended to bypass supraglottic obstruction, although we can talk about how it might also help with that, even though it's not physically stenting that area open. And so this is an example of a scope of a patient with cerebral palsy. You can hear kind of that. I don't know if the audio is coming through.
No, we can't hear the audio.
I won't do my impersonation of the worst snoring, but use your imagination. It's kind of gasping for air, snoring, essentially snoring while awake. And what you'll notice is, again, essentially complete retropalatal collapse, complete retrolingual collapse, but the glottis is pretty wide open, right? And so that was kind of the pattern that I was seeing over and over as I was, caring for more and more of these patients with cerebral palsy, is that there seemed to be low tone that was causing complete retropalatal collapse and complete retrolingual collapse. But most of the time, the glottis was kind of wide open. And so now we'll look at a scope with the device in place. So here you can see, you'll see me introduce the scope through the device. And what you'll see is kind of the device stents the airway open. So this is retropalatal. See a nice open conduit for air. And if the audio was working, that really bad snoring that you heard in the first video is pretty quiet in this video. So it really maintains an open path for airflow. And then this is retrolingual. And same thing, kind of maintains a nice open channel for airflow. And then a question that quickly came up, like, who's going to tolerate placing something in your nose? And a big focus on the device design was optimizing it for comfort. And so the tip of the device is more of like an obturator. It's kind of a soft, gentle tip. Whereas when you think about an endotracheal tube or a nasal trumpet, that's designed more like a core biopsy, right? So the device is also soft medical grade silicone, but the design of the walls of the device, while it's soft, it has kind of design within the walls to prevent it from collapsing. And so we were really fortunate to have success in getting NIH funding to do a clinical trial with the device. And the mechanism is really fascinating. It's an R61, R33, a newer mechanism that NIH offers. In the R61 phase, it's a pilot phase. And what's really neat about this pilot phase is I'm not blinded. The team is not blinded at all. We're able to kind of see, how the patients are doing and able to see all the outcomes and really decide, is the structure of what we're proposing for the main phase, the R33 phase, is everything, set up well. And I think it's a really nice kind of preliminary phase to, one, allow small adjustments if need be, if the device, needed to have a design optimization, or if we needed to shift what quality of life assessments we wanted to look at. We had a chance to do so without major disruption to kind of the main clinical trial. And we'll look at some of the outcomes in that first phase. And then the R33 phase, which we're currently 2 years into the R33 phase. So about halfway through. What we're doing is we're looking to enroll 40 patients with hypotonic upper airway obstruction with an AHI of 10 or over, or greater than 5 with oxygen nadir 75% or less. And we're looking at a number of baseline assessments, quality of life indices. We'll look at kind of all of those components. We're scoping the patient in that enrollment exam. And what particular dimension I'm looking at is kind of the length from the nasal sill to just above the epiglottis. And we've gotten to the point now where we build up kind of enough of an inventory that if you think about this as like shoe sizes, we essentially have kind of all the shoe sizes right-sided and left-sided to be able to give devices to patients kind of whatever airway length they have. I really love the design of this randomization, and this came from a great suggestion from Dr. Shervin. And so there's 2 groups. One group gets the device kind of right off the bat. Patients are coming in with a clinical PSG, diagnosed with the inclusion criteria. And so one group gets the device right off the bat. One group is called waitlist controlled. And the idea with this waitlist controlled is kind of like if I have a patient come in and I'm recommending adenotonsillectomy, it's typically not going to happen that week, right? There's kind of this inherent delay before it gets scheduled, so family can prepare for that. And similar to CPAP, like if you prescribe CPAP, it doesn't instantaneously show up in clinic. There's kind of a delay before it's delivered. So that's kind of the rationale behind that waitlist control. And it also gives us a really clean comparison group. And what I love is kind of the primary assessment point, which is looking at AHI and PSG parameters, as well as quality of life. That primary assessment is after 8 weeks, where we repeat a PSG either with the device in the treatment group or without the device in the control group. Now, one thing that I love about this design is that control group at that 8-week point then gets the device. So everybody has a chance to use the device. There's an additional 8 weeks where both groups are able to use the device, and then a 16-week PSG and quality of life assessment. So inclusion criteria, patients have to have hypotonia. So typically we're looking at patients with cerebral palsy, trisomy 21, but other syndromes as well. We've had a patient with trisomy 18 who had hypotonia and is in the trial. Obstructive sleep apnea, that's severe in the pediatric world. So AHI greater than 10 or an AHI greater than 5. And again, O2 nadir less than 75. And the age range we're looking at is 3 to 21. The reason I didn't want to go younger than 3 is particularly in this trisomy 21 population. My clinical experience has found that if patients have obstructive sleep apnea on the younger end of trisomy 21, they pretty frequently have laryngomalacia. And we kind of look at what's an exclusion criteria. Well, supraglottic airway collapse or more distal airway collapse. So if a patient's got tracheobronchomalacia, they may be a candidate for Dr. Green's external airway splint, but not for this device. We've not seen issues with epistaxis, but we didn't want to tempt fate. So patients who are on anticoagulation or have a platelet disorder or bleeding disorder would be excluded. I think from a marketing standpoint, ultimately that'll be probably a relative contraindication. It's notable that, the study kind of got kicked off during the peak of the pandemic. And so COVID-19 was very much at the top of our mind. And so we certainly didn't want to put the study team at risk, put clinical staff at risk, and potentially exacerbate symptoms for patients. So we excluded active COVID-19. And then certainly patients with predominant central apnea would be excluded. And then patients with severe hypercarbia. The bar here is pretty high. So, looking at end tidal CO2 values greater than 60 for greater than 10% of the sleep time, kind of reflective of restrictive lung disease and that amount of restrictive lung disease. So let's look at, some specific patients in that pilot phase. This was a 19-year-old patient with trisomy 21 who was post-adenoid tonsillectomy. He kind of laughed at all of my attempts at sleep endoscopy directed surgery, and is not a candidate for hypoglossal nerve stimulation because he has circumferential palatal collapse. Has had attempted CPAP, had met with sleep psychologist and numerous attempts to try CPAP, different masks, but was not working. So, with an AHI of about 70, and potential for this level of severity and potential ramifications, I would consider tracheostomy within the realm of discussion for this patient. So when we look at the baseline PSG, which we kind of just discussed, and then with the device, we see a really dramatic reduction in severity. So using AASM criteria down to AHI 17.8, using Medicare's criteria, AHI down to 8.1. And seeing some really interesting patterns with sleep studies. So the baseline PSG really had no REM sleep. And then with the device, we start to see some REM sleep. This is another patient that we'll look at. This patient, 15-year-old with cerebral palsy, severe hypotonia, the type of patient who's kind of obstructing, snoring, awake, wheelchair bound. CPAP, not an option because aspiration risk and asphyxiation risk. And again, with the level of obstruction, tracheostomy candidate. And so this is the baseline PSG, where the AHI is 6.7. Even more striking, I think, is the oxygen nadir at 66. And with the device, we see that 6.7 AHI come down to 0.7, oxygen nadir come down to, or improve to 93 from 66. And so a good proportion of the night without the device is spent less than 90. With the device, that improves pretty dramatically. And then interestingly, again, we see very little REM sleep at baseline, and with the device, saw more REM sleep. In the R33 outcomes, what we're looking at, our primary outcome is looking to reduce AHI by 50%. And we're calling kind of a slam dunk, a reduction to less than an AHI of 15. Secondary objectives, we're hoping to look at clinically observed symptoms by caregivers, so improvements in those symptoms observed, and then adherence to device use, and then importantly, we're looking closely at quality of life, both for the patient and caregivers. So where we're at with enrollment, this was actually for our most recent DSMB meeting. And we've, so the blue line is our cumulative enrollment. The 8 line is patients that have completed the primary endpoint. And we are now at 14 patients recruited, so even higher up and pretty much on target. The wintertime is always challenging because our scheduled PSGs and can frequently be delayed by upper respiratory infections, most commonly. When we look at the demographics of these patients, you can see kind of the breakdown here. We have some diversity represented in our patients, looking to increase that. The mean AHI 31.7, the mean oxygen nadir 73.2. These patients are spending a good amount of the night, less than 90% at baseline. And then you can see some of the quality of life indices that we're looking at. So the Epworth, the SRDB-22, OSA-18, PEDS-QL, and Family Impact Questionnaire. And Dr. O'Brien was really critical in helping us think about which quality of life assessments were going to be most valuable to focus on. I show this, which is kind of our list of completeness of clinical data that we're obtaining, really to give great credit and thanks to our clinical trial team. We've got a really amazing clinical coordinator team, really led by Leah Franco, and the completeness of the data that we're getting is really, with credit to that clinical coordinator team. Importantly, we've had no serious device-related adverse events, which is, a bit of a testament. These patients are not otherwise healthy. Comparing this study with the PATS trial, which we just completed, which was largely in patients who are otherwise healthy with mild sleep disordered breathing. This is quite a distinct group of patients, and I'm very grateful that there have not been any serious device-related adverse events. So this is not from Australia. This is from Traverse City, but also beautiful geography. But I'll stop there. I wanted to leave plenty of time, just because with this great group, I'd love to get any thoughts on the study, any suggestions. Certainly, if you have patients with cerebral palsy, and the group has been amazing in touching base with me, and it's been very helpful. But certainly, if patients come into your clinic and you think they may be a candidate, please feel free to email me directly, and I'll pause there.
Great. Thanks so much. That was fantastic. I don't see any questions in the chat right now. I don't know if anyone wants to unmute. I don't know, Dave, if you want to keep screen sharing or not, but people can call out their questions as they have them.
Well, thanks for that overview, David. It's a great journey and an exciting future. So fingers crossed. Did you show any talk about this at all in Australia, or have you gotten feedback at meetings?
I did. Throughout the week, I actually talked pretty extensively with Dr. Sullivan, and he's pretty keen on the possibility of trying to do a trial in Australia. He's also really, I brought up the question of, is there any potential clinical benefit to combining the two, both from a device standpoint, or just a cumulative clinical benefit. And his hypothesis was yeah, he was really excited at the possibility that either, the two could work kind of hand in hand. But he was really kind of excited about the device. I'm always part of me is you know a little sensitive to the fact that talking to the person who invented CPAP, that they may say, why would you want this thing when you could have CPAP? But actually quite to the contrary, he thought it was um, a really brilliant idea, and kind of couldn't see why it wouldn't work. I was excited to kind of help discuss maybe getting something going in Australia.
Thanks, Fozzie. I see you put something in the chat there.
Yeah, and I know, Dave, we've talked about this often. Sometimes it's so difficult to score the arousals in this patient population and get an adequate AHI just because their background EEG is so abnormal. And we're often having to score it with DSATs. I think that is always going to be an ongoing issue, is how do we reach the AHI of 5 or 10, knowing that it is so difficult with their exceedingly abnormal background EEG.
Yeah.
And I don't know what the way around it really is.
Yeah. It's such a great, point, Fauzia. And I also wonder, kind of to the point, maybe there's a cumulative clinical benefit with relieving the upper airway obstruction and CPAP. Perhaps there's clinical benefit to the NPA device and oxygen.
And I'm wondering if we should take instead of just like DSAT down to 75, should we take the cumulative percent of time below 90 as also a reason to use an NPA device?
Yeah, it is. I'm always struck when I see a sleep study in patients, like cerebral palsy patients, where the AHI might seem really mild, right? But then there's really deep DSATs, or really a prolonged amount of time less than 90, right? So really excellent point, Fauzia. There was quite a bit of discussion in the meeting in Australia, about some of the kind of inherent challenges with AHI. And I was actually texting back and forth with Louise O'Brien. There was kind of discussion with, are there other measures we could look at? I'm just pulling up my hypoxemic burden. Is that something that may be clinically meaningful? So. Are you guys, have you looked at hypoxemic burden as a measure?
We have not used it clinically. It does have support in literature, and it's interesting, and people are still working on what are the mechanisms by which sleep apnea or produces its bad consequences. And in general, those are broadly you can look at sleep disruption, or you can look at hypoxia, and hypoxic burden is a pretty good measure. Clinically, we, like other labs, mostly rely on percent of time under 90, or something like that, or the minimum oxygen saturation, which in my own research, although it's criticized as a net point measure, it's just 1 point in the night that you get your minimum. So how can it be that useful? I haven't been able to distinguish that it's less useful than the more complicated measures, but I haven't done a lot with, to my knowledge, unless somebody else on the call has. with hypoxic burden, which I think is basically amounts to like area under the curve, right? Or area under a flat line and area under.
Yeah.
But it'd be interesting to explore. And I think a big issue for a lot of these kids who already have vulnerable brains, vulnerable neurological issues, be it CP or other, to what extent are they sensitive to OSA, especially from early ages, and to what extent is that contributing at all to their cognitive and behavioral outcomes?
Yeah, really, a really interesting question. I will say perhaps one of the most professionally rewarding experiences has been participating in this study. And I'm blinded in the R33 phase to the sleep outcomes, but I clinically follow the patients and as part of the protocol, follow up to make sure that device use is going well, and kind of hearing the families give feedback that whereas the school would call daily because the patient was sleeping the entire time in school, and now they're awake and focusing and paying attention in class. Those types of anecdotes have been really invigorating.
Yeah, it's a big difference. Can I steal 2 minutes to put in a plug for a related study also?
Sure.
So we just started the DOSA study, DOSA. That's vaguely stands for obstructive sleep apnea and Down syndrome. And we're recruiting as of this month. So I would like especially any help from the fellows or anybody else on the call. Fauzi and I are both working on this. We're looking for children who are 5 to 17 and who have Down syndrome, have a history of adenotonsillectomy, or I suppose if they completely refused it, usually they have a history of adenotonsillectomy, and they have failed or refused CPAP. And those children are eligible to enter into this new study that we have, which will randomize them to oxygen or just nasal strips as kind of a comparison group. But the real thing is to see whether if we can titrate them on oxygen to treat their residual sleep apnea, whether that's going to have benefit 6 months out on cognitive measures, behavioral measures, cardiac measures. They get echoes. So we're very eager to do that as another. I mean, you had 1 or 2 Down syndrome patients, I think, with the nasopharyngeal airway device.
Mm-hmm.
People are very motivated, these children, where it's hard to treat their sleep apnea for one reason or another, to find some solution. And like you were saying, it's so gratifying if you can. We're hoping that children may be able to tolerate a nasal cannula of oxygen better than they tolerate CPAP. So
yeah, it's remarkable. Our youngest trisomy patient was 7, and he tolerated the device quite well. When kind of family talked about comparing tolerating CPAP or the device, they felt it was much easier to acclimate to the nasopharyngeal device. So much, as in CPAP, I feel like a lot is dependent on kind of that caregiver support, right? And so I think if that is there, it really kind of opens up doors.
absolutely makes a big difference.
I think the caregiver perspective has been really fascinating too, particularly with this study. Another kind of anecdote was, and I've heard this actually repeatedly, of parents, kind of waking up hourly to have to check on their little one, make sure they're still breathing. And within the study, we have patients who we will have, pulse oximetry use just as a safety measure. And, some of these families have reported that, the pulse oximeters, stops going off, and they're actually able to, the parent themselves is, for the first time in years, able to sleep through the night. So you know, certainly the primary goal is to help the child, but I think that we're potentially also helping the entire family unit.
It's like young children and older people, you benefit way more than just the patient. Middle age too. Sometimes you're giving them a quieter night of sleep.
Yeah. Well, thank you so much. Again, I always really love chatting with this group, and I'm so fortunate to have amazing colleagues in sleep.
I have just a few practical questions.
Sure.
Okay. I guess just like about, like, can they still use this when they get sick? I know like in some of the intro slides you showed that there's, I guess, some little holes to try to help with secretion. I'm just thinking this is a patient population that gets sick a lot, that has a lot of secretions anyway at baseline. And like, they probably can't clear the air. Like, does it get clogged, with something? Like, do they have to suction it? Or does it just kind of fix itself?
Great question. So one of the main design components to it is to avoid clogging. Unlike like a nasal trumpet, which is like a closed tube and can occlude pretty easily with secretions, this is open channel. So secretions can get in, but they pretty quickly get out. Actually, having kind of worked with the device for several years now, I've never, knock on wood, seen one get occluded. And having taken these out clinically, they don't accumulate secretions just because they're open. It would kind of be like, if you had a cup with a hole in the bottom, it's not gonna retain fluid. And so fortunately, we're not seeing signs of occlusion. It's a really interesting point. What do we do during an upper respiratory infection, right? Especially this time of year. And it's a question that came up and we discussed with our DSMB. I think, so the approach that we've taken is basically given the family the decision if they want to pause using the device until the symptoms resolve. That's certainly an option. If they want to continue using the device while there are symptoms, that's an option too. And what we found in all instances are that families continue to use the device because it helps with breathing. And the other really interesting thing is we've had families report that basically every cold and flu season, they can pretty much, make their reservation for the ICU. They know that, if they get a cold, they get upper respiratory infection, not only do they, have to struggle with congestion, but they end up in the ICU and sometimes intubated. And one thing I think we'll be able to look at kind of at the end of the study is, has the device, during device use, when the patients are on study in those cold and flu seasons, is this reducing ICU admissions, intubations, ER visits? And I can kind of tell from a bird's eye view, hypothesis based, I think we'll see that seems to be the case.
Thank you.
Sure.
And I may have missed it. So it sounds like you're still recruiting.
Absolutely. Yeah. We're about halfway through. So we need a good, 20 or so more patients.
I see. Yeah, because I think from one of my patients, like, I guess this isn't something that they can continue to use until it's FDA. Like, they only get it for like the 8 weeks or 16 weeks or something, and then they have to give it back and wait. And so the timeline. Oh, sorry.
Oh, yeah. So after 16 weeks, currently they have to stop using it. We have, 2 options currently, which is kind of revert to the customized endotracheal tube version, which has been beneficial for some patients, or utilizing a nasopharyngeal trumpet. The other thing that we're in the process of doing is getting an IRB approval to extend use if it's providing clinical benefit for an additional year. we actually just had a call. Dr. Bryan was on it as well with the FDA earlier today. And so we should get kind of additional clarity as to, what will be necessary for getting FDA approval. There's really strong interest from colleagues across the country, particularly Seattle Children's, Colorado Children's, Cincinnati, to be able to use the device, almost thinking about like a multi-center trial. I think the IRB kind of 1-year extension will be really nice, just because there's been a lot of patients where it's working great for, and it is a challenge, to balance kind of the regulatory restrictions because it's not FDA approved with, the fact that you have something that is working well for families. So I think that 1-year extension will be the way to go.
Thank you.
Thank you.
Thanks again, Dave. I think we got everybody's questions and comments, but thank you for a wonderful talk and for your partnership. I look forward to having you back soon.
Thank you. Have a great afternoon, everyone.
Thank you.